embryonic or fetal death. And as obstetricians, it is our duty to try and prevent those infections and educate the women about the ways they can prevent it. The mother-to-baby transmission of infection can occur in 3 ways, either in utero, or perinatally at or around the time of delivery, or postnatally also through breastfeeding. In general, we have to remember that primary infections during pregnancy are substantially more damaging than the reinfections or reactivations of infections. And infections which are acquired at an earlier gestational age have serious implications as compared to the infections which are acquired at later gestation. So, the viral infections can cause different effects on the pregnancy, leading to possible miscarriages, congenital anomalies, fetal head drops, fetal death, preterm delivery, and preterm premature rupture of membrane. So many times the infections have direct effect or indirect effect by causing preterm delivery or intrauterine growth restriction. So I will talk about first infection, rubella infection, which is an RNA virus with an incubation period of 2 to 3 weeks. And the mode of transmission is through respiratory droplet infections. And viremia generally occurs 5 to 7 days after the contact, during which time the virus may be transmitted from the mother to the fetus through transplacental spread. I will not go into the details of the picture of congenital rubella syndrome. All of us are aware about it, but it is a common cause of having the fetus is at risk of cataracts and hearing impairment and microcephaly. The incidence of these congenital anomalies depends on the gestational age at which the rubella infection occurred. So, if it is occurring in first 8 weeks, the chances of fetus getting affected and developing congenital rubella syndrome is 90%. And when the infection develops from 9 to 12 weeks, the risk of infection is 50%. And whereas if it develops between 13 to 16 weeks, the infection risk reduces to 15%. And the risk of fetal damage falls steeply after the first trimester, and especially after 16 weeks, it is negligible. So it is the first 16 weeks which are important. So I'll directly, rather than going on to the clinical features, I'll talk about how do we diagnose rubella infection. So in the mother, recent infection can be confirmed by presence of rubella-specific IgM or rising IgG antibody titers. There are scenarios when the initial rubella-specific IgM is negative, and if that sample was taken within 5 days of the rash onset, it is worthwhile to repeat the serology because it may have been, the initial sample may have been too early. Rubella-specific IgM may persist for 6 weeks after the onset of rash, which can sometimes cause diagnostic dilemma. Diagnosis can also be made by positive rubella viral culture and detection of the rubella virus by PCR. I will talk about next viral infection, which is cytomegalo. Cytomegalovirus is a DNA virus, and there is a 40% risk of transmission in the first half of pregnancy when the mother develops primary maternal infection in the first trimester. However, the risk of severe congenital infection is 1%. 5 to 15% of the infected neonates, they show acute clinical symptoms at birth. And of these severely infected infants, up to 30% die, and approximately 80% of the survivors will have serious sequelae. So even though the risk of congenital severe infection is less, but the sequelae are quite strong. And the neonatal mortality rate goes up to 20%. So 85 to 90% of the infected infants are asymptomatic at birth, and 10 to 15% of these initially asymptomatic children subsequently develop neurological, auditory, visual, and other symptoms which become evident as they enter school. So if the primary maternal infection occurs in third trimester, so interestingly, when the primary maternal infection occurs in the third trimester of pregnancy, the risk of placental transmission is much higher, amounting to 75 to 80%. However, it is important to remember that the risk of serious fetal injury is very low if the primary infection is in the third trimester. How does the CMV virus spread? The CMV spreads through infected persons' secretions like saliva, blood, urine, semen, cervical and vaginal secretions, or the breast milk. And also important to remember that CMV survives on fomites, including diapers, toys, and hands. So the women who are working in daycare centers and handling the infants or preschool children, they are at risk of developing CMV infection. And also women who take care of their children at home and share their share the same utensils while eating, or they like kiss on the baby's face or the lips, are at risk of developing CMV infection. How do we diagnose CMV infection? So serum IgG is not always a sensitive test for primary CMV infection. And likewise, IgM is also not highly specific, since the mother may have false positive results because of the cross reactions. So in these scenarios, IgG avidity testing can be extremely helpful in differentiating between whether it is a chronic or acute infection. So in acute infections, the avidity test will show low avidity, whereas in recurrent or reactivation, there is high IgG avidity. But unfortunately, avidity tests are not very easily available in many places. So how do we diagnose the congenital CMV infection? So there are two ways of diagnosing congenital neonatal infection, either by amniocentesis, where we look for CMV DNA and after 22 weeks of gestation, and the second option is chordosynthesis. But chordosynthesis is, as we say, that in early pregnancy it is not a feasible option for as a diagnostic modality. And the third option is ultrasound diagnosis of and searching for the various markers in the fetus, like intrauterine growth restriction, intracranial calcifications, ventriculomegaly, or hair drops, but it has low sensitivity and specificity for the fetal disease. So how do we treat if the mother has CMV infection? So antiviral agents like ganciclovir or foscarnet or cidofovir, but they are not of proven value in preventing or treating the congenital CMV infection. So it is important to remember that once a mother has developed infection, it will not, if the fetus gets affected, it will not be prevented by taking antiviral agents. However, the most promising therapy which is upcoming is for the congenital CMV infection is by hyperimmunoglobulin. The third infection which I'm going to talk is varicella and during pregnancy.
Just to let you know, ma'am, the time is up. So if you could sum it up in the next 30 seconds, would be wonderful.
Okay, yeah. So varicella infection, there is a risk of fetal varicella syndrome, which is amounting to about 1%. And so important is to remember, whenever there is a mother who has been exposed to someone with varicella infection, within first 10 days we can give varicella immunoglobulin. But however, if she develops varicella infection, then there is no role for giving immunoglobulin. In that case, we give acyclovir, usually after 20 weeks, but also we can consider if the mother develops varicella in even before 20 weeks. And it's important if the woman develops varicella in the, I think I will just talk about the diagnosis. The women who develop chickenpox in pregnancy should be referred to a fetal medicine specialist at 16 to 20 weeks of gestation or 5 weeks after the initial infection for discussion and detailed ultrasound examination. And other diagnostic modalities are amniocentesis combined with ultrasound can give a good result about possible diagnosis of fetal varicella syndrome. I think the topic is too vast and I have many more slides, but then I don't think I can finish it off in 10 minutes.
Thank you
so
so
I'll stop here.
Thank you so much.
Thanks. Yeah.